Good
Did you want to?
afternoon.
Oh, go ahead.
Thanks for joining us. I'm just going to give a few minutes to let people come into the room. All right, I know a bunch of you might be joining us during your lunch hour, so we'll get started right away. My name is Martina. I'm with Beam Readers, and I'm introducing your speaker today, Samantha Gallia. She's an oral maxillofacial radiologist, graduated from the University of Pacific for dental school, and then attended the University of Washington for her OMR residency. She's been with the Beam Readers Company, and all of her clients adore her. I'm sure you will too. And so I'll let her take it away.
Hi, everyone. Thank you so much for joining us. It is an honor to be here with you all. So we'll go ahead and get started. Our topic today is the CBCT Collective from Decision to Diagnosis. And session 1 of 3 is going to be focused on what, when, and who of 3D imaging. So this is meant to be an introductory CBCT course. And today's topic is really going to focus on the foundation and principles of CBCT. So kind of everything before we push that button that we're going to consider. So Martina already mentioned it a little about me, UOP Dental School, University of Washington for residency, and I live in Sacramento, California, where I was born and raised. And I had to find a way to sneak this in there. My favorite thing of all time besides radiology, my dog. I thought this was relevant enough today. This is his Halloween costume. So I will let that be our precursor for today's talk. So disclosures, I'm a radiologist at Beam Readers. That's it. And our disclaimer for today is this is an introduction to CBCT course. So, there's so much to learn when it comes to 3D imaging. It took me 2 years to even feel like I was beginning to learn all that there is to learn. So, don't feel like you have to learn everything that there is today. Again, today's session 1 of 3. And even after session 3, it's just going to be a really great point for you to continue launching your learning journey. So in everything, you're always responsible for knowing the limits of your knowledge. And a little bit of housekeeping for today. Feel free to take notes of the screen with screenshots, but this meeting is being recorded, so everybody's going to get that recording afterwards. So if you just want to be here and be present, this is really meant to be more of a study club format than a lecture. The first half is going to be a little bit lecture-y because I want to be able to share some knowledge with all of you. But if throughout the talk anybody has any questions, please feel free to raise your hand or ask it in the chat. Martina is going to help me be managing those, so I will get notified of them and we can address something right away. Or if you want, there's going to be plenty of time designated after the talk for Q&A about whatever you got. So feel free to please ask questions. It makes it so much more interesting than me talking in a room by myself. That's no fun. So a little overview of today's agenda. We're going to go over what is CBCT, how does it work, risks, benefits, and limitations, a little bit about radiation safety, and then most importantly, gaining patient acceptance, how you're going to be able to successfully integrate this into your clinical practice. And this is really where I want to start. With me, there are no dumb questions. There's only dumb people who don't ask questions. The most important thing that I learned throughout my residency is that it is so important that you ask every question under the sun. Like I said, it took me so long to learn all I know about CBCT, and there's still so much that I don't know. So I really invite you to ask all questions that come to mind. I wanted to share a little anecdote from actually my first week of residency. I think it was maybe first or second day, and we were in our first radiology lecture with all of the residents. So it wasn't just the radiology residents, it was all the other residents who perio, prost, ortho, everyone. And they were scrolling through a CBCT image. It was one of our radiology faculty and just asking us, what do you see? Which is a super common thing to ask when you're learning about 3D imaging. And I, noticed something. So I raised my hand and I said, there's actually a break in the buccal cortex near the premolar region. And somebody turned to me and goes, yeah, that's the mental foramen. And at that moment, I felt really silly for asking that question. But I look back and you don't know what you don't know. So please ask questions, because I guarantee if you have a question, somebody else has that question too, and they're just too nervous to ask. So seriously, this is beginner course. There's nothing too small to ask, better to ask now. And also with that, I'm going to be going into the basics. So if this is stuff that you already know, that's okay. Just consider it a refresher. All right, so getting started, what is CBCT? CBCT stands for cone beam computed tomography, and it provides a three-dimensional volumetric data in axial, sagittal, and coronal planes. So we'll go over kind of what each of those planes mean later on, but for right now, in the lower right image here, you're seeing what's called the volume rendering. So that kind of shows an overview of our image. And this is a pretty typical multiplanar reconstruction that we use to look at the different slices of CBCT. So we're looking at axial, sagittal, and coronal. I'll go through kind of what those mean later. And the biggest thing to know is CBCT allows us to visualize in the third dimension. So as opposed to, 2D images like panoramic or intraoral images, we are actually seeing all of the 3D structures as opposed to seeing things kind of superimposed on each other. And there's 3 steps in the CBCT imaging process. There's image production, visualization, and interpretation. So we'll be going through each of those in this 3-part series. And another important thing to note is that CBCT is relatively low ionizing radiation to the patient. And we'll go over what that means, why it's relatively later. So how does it work? I know this is kind of the boring part. I'm going to try to not get into the weeds too far. I'm just going to give you the information that I feel like is imperative for you to comfortably know what's actually going on when you take a CBCT. So this is a really great diagram. It's from one of our favorite textbooks of 3D imaging, White and Farrow. And a little rundown of what's going on here. So the machine has an X-ray source and an X-ray detector that are opposite each other, and they rotate around the patient's head in a circle. As they rotate, a cone-shaped X-ray beam passes through the jaw and face, and the detector captures hundreds of separate 2D images at different angles. So all of those images are sent to a computer, which uses a reconstruction algorithm to combine them into a 3D data set or a volume. And you can scroll through those in the planes that we just talked about. So because the system uses a cone beam in a single rotation instead of multiple helical slices like a medical CT, that is why CBCT is typically less radiation compared to a medical CT. And all of this is happening relatively quickly, so in 5 to 30 seconds. That is longer than 2D radiograph, obviously, but it is relatively quickly compared to other types of 3D imaging. All right, little bit of key terminology. Yawn, I promise this is the last boring slide. So we've got a voxel. A voxel is a 3D pixel. And the important thing to know is that a smaller voxel means a sharper image, but more radiation. We'll touch more on this later. Field of view is how much of the head is included in your scan. So with CBCT images, we can either take a really small field of view, like a single tooth, all the way up to a really large field of view, like the entire maxillofacial complex. And every machine is a little bit different with the field of views that they have the capability to take. So it's really important to know your machine and know what it's capable of. And then reconstruction means the process of turning 2D captures into that 3D volume that we actually see. And then, like I said before, going over the actual views that we use mostly to look at CBCT. So starting up here in the upper left, this is going to be the axial view. And this is going to be slicing through the patient from top to bottom. So I always like to picture that the patient is laying down in front of me and you are literally kind of scrolling up and down through the patient. So this image is taken at the level of the mandible. And we can see that there. And then moving on to the sagittal view, we have the, this is scrolling through the patient left to right, left to right. So this is kind of when you're looking at the side of a panoramic image. So we can see the cervical spine here. That is what we can see in that one. And then coronal view, this is usually the image that dentists are the most comfortable with because it's like looking at the center of a panoramic image. And this is like we are scrolling through the patient from front to back. So kind of like they're standing right in front of you, looking at you, and you can scroll through the features like this. And then we have our volume rendering on the lower right. So custom slices and views. The other really cool thing about CBCT is while we usually use those classic ways of looking at the volume, we can also create custom views. So things like looking at the TMJs, looking at the airway, and my personal favorite way to look at a scan is what's called this arch section view. So we can create our what's called an arch spline custom to the patient's arch, and then we can actually scroll through the arch. And this is really, really good for creating an image like this for bone measurements for implants, and also for looking at periapical pathology. So later on, after today's session, we'll talk, specifically about how you can create these custom views that are helpful. And here's our example showing how we look at our TMJs. So right here, this is the axial view of the TMJs. These are the condyles. And then here we are able to see through the TMJ right there. So this is the right side and this is the left side. And we can clearly see some findings on the left side. We see some sclerosis, we see an erosion, a lot of stuff going on there. All right, so moving on to advantages of CBCT. Obviously, visualizing it in the third dimension is a huge advantage, visualizing in a variety of the views and slices we talked about. There's no superimposition of anatomic structures like there is with panoramic imaging. So in a panoramic image, obviously you're looking at a 3D structure with 2D radiographs. So you're seeing, superimposition of a lot of things, especially in the sinus region, that we have to kind of interpret and figure out. And it's actually very difficult to figure out what exactly each line means. In CBCT, you are looking at exactly what each structure is in the location that it is. So that's really nice in a way. Once you understand the technology, parts of it, I think, can be easier than interpreting panoramics. And then there's no magnification or geometric distortion like we see in some of our 2D images, panoramics, PAs. And then radiation dose wise, like I mentioned before, it is generally lower compared to medical CT imaging. So if you're wondering why wouldn't every patient just have a medical CT, that is much higher radiation dose. And that also doesn't allow us to see as fine detail of the dental and osseous structures as CBCT generally. That's awesome. And then moving on to a few limitations of CBCT. So I think one of the most important things that you can get from today is understanding the limitations of CBCT so that you can know when it's not appropriate to use it. Because we always love, we want to use this bright, shiny new technology that we have, but it's really important that we're practicing the principles of ALARA as low as reasonably achievable and only taking radiographs when they're going to yield something that we can use diagnostically and clinically. So some of the limitations of CBCT, the biggest one I would say is limited visualization of soft tissue. So the clinical implications of this are in the TMJ specifically, we can't see the articular disc. So you can see here on the left, we have a CBCT image and we see our condyle, we see the glenoid fossa, we see the articular eminence, but there's something that we know is in here. It's the articular disc and we can't see it. And that's because we have limited visualization of soft tissue in CBCT. Whereas there's other imaging modalities like MRI that do have the capability of visualizing the articular disc. And in radiology residency, we were trained to read TMJ MRIs. But it's just important for you to know that there are certain times when you might not be able to see the problem that you're looking for on CBCT. Another limitation is that high density objects can create pretty significant artifacts. So high density objects being anything that ends up what you would call radiopaque in a 2D image. So restorations, endodontic obturations, implants, things like that create a variety of different artifacts. A couple clinical implications of this, I feel like the most frequent ones are deciphering root fractures versus artifact. So we can see here the artifact from an obturation creates these kind of little streaks, and it can be difficult to tell, is that a root fracture or is that just artifact? Whereas here on the right, we have a true root fracture and we can visualize it because we don't have any high density object impeding visualization of that area. So sometimes you genuinely can't tell the presence of a root fracture or not. And then deciphering caries versus artifact. This on the right is a really great image from Martina. The blue arrow is showing artifact from a high density restoration. And then the orange arrow is showing what a true carious lesion looks like. So I find a good way for dentists or general dentists that are just being introduced to CBCT to tell the difference of these two things is you have to look at the proximity of the restoration to the low density area you're looking at. There's a certain proximity to a high density object like a restoration that you just can't tell if something's there. You can't tell if there's caries there. And it also, artifact tends to look a little bit more like what burnout looks like. In bite wings where it's a little bit more diffuse, and we can see here that this caries has a more well-defined border. And in these areas, there's no restoration close by, so I can tell that that is real. Again, if anybody has any questions, feel free to raise your hand, hop in the chat. I really want this to be kind of open for everybody to be able to ask questions. And another limitation of CBCT going to be motion artifact. So like I said earlier, it does have a longer scan time compared to 2D. There's definitely enough time for somebody to move, right? And that's one of the things that we'll talk about in a later session for optimizing your image is there's typically with the machine a way to check a way to check before you actually go through the whole scan if there was motion artifact. And it can prevent accurate visualization and localization of structures. So we can see with these arrows some examples of kind of the blurry border that motion artifact creates. It makes it difficult to tell if something is real or not real. And then we got this one. Just stick with me here. It's a little bit nerdy, but we got what's called partial volume averaging artifact. And this is actually a really important thing to understand within CBCT. So I love this diagram here. Partial volume averaging is the phenomenon that when there's two different densities of structures located within one pixel, they get averaged. So remember we talked about voxels and pixels. In this diagram, every single one of these little squares in this grid is a pixel. And when there is an object filling a pixel, so let's say it's cortical bone, When that object is in fully taking up 1 pixel, it shows up exactly like it is. So it shows up exactly like cortical bone. Whereas if there is an object that is present with another density in that certain pixel, so let's say it's cortical bone being next to soft tissue, that pixel actually gets averaged. So this example right here of where we see a little bit more diffuse and lighter color than the actual object is a really good example of how that can cause an object to become a little bit more diffuse and not show you where the true border of that object is. And so hopefully that wasn't too confusing. I know it's a confusing topic, and we could talk about it more later, but basically, it makes it difficult to evaluate the presence or absence of thin structures. So clinical implications of this are going to be thin buccal bone. So telling if you're trying to tell whether or not there is buccal bone presence. And then floor of the maxillary sinus is another really thin object. So for example, right here, we can clearly see that we have periapical pathology at this molar. And right here is the floor of the maxillary sinus. And there's this area where it looks like the floor of that maxillary sinus is missing. But is the bone actually entirely missing? Or is it just partial volume averaging that we can't tell? Difficult to say. Finally, last limitation of CBCT is going to be cost. It's a limitation for you. It's a limitation for your patients. And at the end of today's lecture, we're going to talk about kind of how to mitigate that with patients and how to get them to accept your treatment. So now we're going to go into some risks and benefits of taking CBCT. FYI, I'm going to try to wrap up by no later than 12:45 for the more lecture-y part of this so that we can have plenty of time to ask questions too. So if you want to, go ahead and write down any questions as we're going. It's a great turnout, but a small enough group that we can have specialized specific questions. So jumping into the risks of taking CBCT, first one, obviously radiation dose, generally higher compared to 2D imaging. And I've got some specific numbers for you guys. It's always going to be a little bit different with every 2D image, every CBCT machine, depending on the type of collimation you're using, your specific machine. But this is kind of a good rule of thumb to go by if a patient ever asks you and wants to know the real numbers. So we're measuring in microsieverts here. A single PA radiograph with rectangular collimation is about 2 microsieverts. Single PA radiograph with round collimation is about 9.5 microsieverts, and we're comparing that to 84 to 212 microsieverts with CBCT. So there's some other really good resources online that can give you examples to kind of how much radiation is a CBCT performs generally. I always like to have those in the back of my mind in case the patient asks, kind of comparing it to real life situations like you would with 2D radiographs. And then I really like this statement. This is from the AAOMR Executive Opinion on Performing and Interpreting Diagnostic CBCT. So it says practitioners using CBCT must have a thorough understanding of the operational parameters and the effects of the parameters on image quality and safety. So this is basically just saying, if you have a CBCT, if you're utilizing a CBCT as the doctor, it is your responsibility to understand the parameters of your machine, the results of these parameters, and how that affects your image quality and radiation safety. So you have to understand your machine so that you can be able to use it correctly. So now going into a little bit about radiation dose, let's go over some of the primary determinants of dose. So the number one is going to be field of view. And like we talked about, field of view is how much of the maxillofacial complex we are imaging. So a larger field of view, let's jump down here to the lower right. We see a lot of images taken like this, which kind of encompass the entire maxillofacial region. That's going to mean more radiation. it's going to mean a larger voxel size because you can only decrease the voxel size so much. So with a smaller field of view, you're able to get a smaller voxel size, and therefore you're able to get a higher resolution image. So with a large field of view, you're actually not able to get as high of a resolution. And then there's obviously more to interpret. And we'll talk about this a little bit later as well, but you are responsible for everything that's taken in that image. So if you get the cervical spine, you're responsible for the cervical spine. If you get the orbits, you're responsible for the orbit. So obviously we need to take as large of a field of view as is important for that indication for that patient. But it's really important that we are kind of customizing the field of view to each patient. We don't want to just be taking a large field of view for every patient, which I know is pretty common. But with just a little education, we'll be able to kind of more precisely pick a good field of view, which makes your life easier, and it ends up having a better resolution as well. So other factors of a CBCT that determine the dose are the MA, which is the number of photons of an image, the KVP, the energy of photons, and time to take the image. And we'll talk a little bit more about those aspects when we talk about taking the CBCT next time. But just those are some of the things that help determine dose and why you often see a pretty big range of dose for machines. So ALARA, we touched on this, but we want to be practicing by ALARA, which means as low as reasonably achievable. And I always like to kind of asterisk that and add with acceptable diagnostic capabilities. So it is super, super important that we are, like I said, customizing every case with the specific parameters that we're using for our machine. So primarily that's going to mean the field of view, but it can also mean, what resolution we want to get with that image. So it can be kind of tempting to say, let's turn down the settings on our machine. Let's do a lower KVP, a lower MA because it's lower radiation. However, if you are not getting a high enough resolution to see what you need to see in that image, it's not worth it because it's not giving you the diagnostic yield that you need for that image. So we need to make sure that we're getting acceptable diagnostic capabilities for each image. And so this just means you got to create some kind of protocol for your office, and it's going to be different depending on what you're using your CBCT for mostly, but determining kind of, okay, I'm going to use this field of view generally when it's this type of case. And it's really important to kind of come up with that because oftentimes we're not the ones taking the CBCT. So we can talk about some of that stuff too and kind of how to create a game plan moving forward to that. So in general, to CBCT or not to CBCT, that is the question. And we'll go forward and talk a little bit about times that you want to take an image, times that you don't want to take an image, because we have to be really specific in figuring out between those two things. So these are a couple questions that I like to ask myself before I take a CBCT. So the golden question overall is, when does CBCT add value? That is what we're looking for because we need to be getting something out of this image that we're taking. So the three minor questions that I ask are, A, is there a specific clinical question that I'm looking to answer with this 3D image? Is there necessary information that 2D imaging can't achieve? Because if I can get something from 2D imaging, I want to do that. It's less radiation for the patient. And then lastly, will 3D imaging change my diagnosis or treatment plan? It's very tempting sometimes to just take a CBCT to gain more information. As a radiologist, I'm like number one victim for that because I always want to know, right? I always want to know what's going on. But if it's not actually going to change the treatment plan, it's not worth it. It's not worth the radiation to the patient. It's not worth the cost for the patient. So it's only if there's a yes to all three of these that we want to take the scan. All right, so this is pretty generalized. However, just to give you like an overall idea, I like this list. So we're going to have clinical situations that will likely have a high diagnostic yield. And I'll let you read through those. But there's obviously a lot of times when taking a CBCT is going to do those things for us. It's going to change our treatment plan and is indicated. The biggest times that it's not recommended are when you're starting to generalize and not look at a patient's case specifically. So general screening, we don't want to be taking a patient on a CBCT on every single patient that's walking through the door. Generalized periodontal disease, it's not really going to give us any more information. Unless we're looking for something specific, and then caries detection. So CBCT is often limited in the ability to detect caries because of the partial volume averaging artifact that we mentioned earlier. So 2D radiographs are often better for that anyways. So those are some things that we don't just want to kind of generalize, take a scan always. And then these are some reasons that are pretty often a good reason to take a CBCT. All right, so now we'll go into some risks of not taking a CBCT. So first we have incorrect or delayed diagnosis. So obviously increased duration of pain for the patient, increased risk of complications, and increased financial cost. And this is an area that I think we're going to talk more about patient acceptance in a little bit, but if you are not able to correctly use the tools that you have to diagnose what's going on, oftentimes it can end up costing the patient more, right? Because we can try a root canal, but if there's a vertical root fracture that we could have seen on a CBCT, the tooth was going to have to be extracted anyway. So there's, a lot of times when it ends up being more costly for the patient if you're not able to perform all the diagnostic tests that you can. And then on the liability end, even if you have a patient sign a form stating that they willingly refuse radiographs or willingly refuse taking a CBCT, no patient can be given consent for the dentist to be negligent. So basically there is no, and I know there's like always different information about this floating around, but there is absolutely no way that a patient can sign off for not having the appropriate radiographs taken. As the doctor, it is up to you what radiographs need to be taken in a specific patient's case to be able to yield all the diagnostic information that you need to make your treatment plan. And if they don't want to move forward with that, it does not get you out of the liability there. And this is also true for a radiology report. So there needs to be a radiology report written, whether it's in your notes or a separate document for each CBCT that's taken, just like 2D radiographs. And then moving into medical legal considerations. So most important things, and this is super, super important because you want to be protected, right? And you want to kind of know the risks of when you're taking any kind of image or test or anything. So you own every image that you prescribe and every finding in it. That includes all anatomic structures visualized on the scan, not just the teeth. So really often in large field of view scans, we're seeing cranial base pathology, we're seeing sinus pathology, we're seeing, stuff elsewhere besides the teeth. So if you are not comfortable with the anatomy of the area that you are taking a scan on, I would highly consider taking a or submitting for a radiology report to get the medical legal aspect off your hands. Because if something appears abnormal and you don't document it, the liability falls on you. You are held to the same standard as a radiologist. I know that sounds scary, but that's just like every aspect of dentistry, right? If you're going to do a root canal, you're held to the same standards as an endodontist. And you don't need to be an expert in pathology, but you do need to know what's normal so you can recognize what's not. And that's the most important thing. That would be my hope for each of you is that at the end of this, probably not at the end of this, but at the point where you feel confident in your CBCT journey, it's that you feel comfortable recognizing what is not normal so you can send the patient to get the help that they need, whether that's a biopsy, whether it's submitting for a radiology report, whether it's getting a second opinion from a specialist. You need to be able to know what's not normal and where to go from there. So on the left, we have trying to interpret findings in the sphenoid sinus. And on the right, we have referring to an OMR. So, like I said, I work for Beam Readers and we write radiology reports. So, really, occasionally it can be for 2D radiographs, but most often it's for CBCTs. We have dentists who send almost every CBCT that they take because it's just something that they're going to include as a charge to the patient. They say it's necessary and they get the liability totally off their hands. We have a lot of other doctors who feel more comfortable and they just send when they see something wrong, when they see something weird. So totally up to you how you feel comfortable practicing moving forward. I just encourage you to kind of know what your implications are legally and then know your limitations of how you feel comfortable. And then moving on to our last section. So we're doing pretty good with time. This is kind of the last thing we're going to talk about today before I'll open it up to questions, but gaining patient acceptance. So I'm going to go through some things that I have found to be helpful in offices integrating CBCT into their practice. Uh, First one is that everyone's on the same page. Every member of your team, your front desk, hygienists, everyone on the clinical team is knowledgeable about CBCT, what it does in case a patient asks, and they need to believe in the CBCT. So you want to be excited about it. A thing that you can, share with patients is, I'm excited to let you know that we have a new technology that allows us to better evaluate your dental condition, and tell them why you got that machine. We made the decision to invest in this because we are committed to giving our patients the highest level of care. Patients love that. Patients love knowing that you are staying up to date with the latest technology, and also sharing, that not every practice has this. You decided to invest in this because you're committed to giving your patients best quality care. Along that line, don't discount the value. People respect quality. And so I would suggest against the temptation to offer CBCT for free because it can actually undermine the confidence in the technology and make them think that it's not necessary or not important. It's really expensive technology and it's something that you should absolutely be charging for because it costs your office a lot. And then lastly, expect hesitation and have a plan for it. Not everyone's going to immediately say yes, just like not everyone immediately says yes to fluoride, root canals, basically anything. Just be able to feel educated so that when those questions arise, you're able to successfully answer them and to address the patient's specific concerns. So oftentimes I find that when patients push back, they're just asking for clarification. So if somebody says, no, I don't want that, it might actually just mean I don't really understand what's going on, or I don't understand why this is necessary, kind of pushing you to see if it is necessary. And I find this with other areas of dentistry as well. So I think it's really important to understand the reasoning behind needing the scan. For example, if you're looking at a third molar, based on what I'm seeing, this tooth might be very close to the nerve. Before we extract it, I need a clear 3D picture so I can plan the safest approach and minimize your risk of complications. Patients want to minimize their risk of complications. And oftentimes, if it's within their capabilities, they're going to want to do those things when you're being honest with them and kind of explaining why this is necessary. So I encourage you to ask, what is your main concern about the x-ray? This x-ray, listen to them genuinely. And I would say that the two main concerns that we see are cost and radiation. So those are two that we'll kind of go back through. But I think using the technique of paraphrasing their response back to them often makes patients feel understood. And then it also allows you to specifically address their concern. So objection number one that we find often is cost. Acknowledge this one directly. I know the cost feels like an extra expense. That's serious for us too. We're committed to providing great care, blah, 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 blah. So you want to take the question head on. And then you want to also tell them, the benefit and why you need this. when cost is truly a barrier, which sometimes it is, sometimes it isn't. When it's truly a barrier, you want to address that directly, and then you want to be honest and you want to say that you can't deliver your best care for the situation without this level of imaging. And again, it doesn't take the liability off your hands if the patient can't pay for it. So I encourage you to make it accessible, offer payment plans, flexible billing, anything that works in the confines of your specific office's policies to be able to make it more accessible for patients. And then objection number 2 is radiation dose. So this one, again, you want to validate your concerns. It makes sense that you're thinking about radiation. That's smart. I'm also committed to keeping your exposure as low as possible. I often explain ALARA to patients so that they know we're not just taking radiographs willy-nilly. We take it seriously. And then I like to tell them I wouldn't recommend this scan unless it was truly necessary to give you the best care. Because when you're making it clear for a patient that you are giving them the best care and that this is necessary and they will not get the best care without, it makes it a lot easier for them to say yes. And then, like I mentioned before, I really like to compare the radiation doses to, things in real life, saying, this 2D radiograph is like living on Earth for a single day. And you can find a lot of those comparisons online for the different doses. But I think that helps patients kind of conceptualize what is going on, because overall radiation doses have decreased so much in the past 100 years of dentistry, and that's not really well known to patients. So it's really important that we let them know, hey, this is something that is really it's still important, but it's so much less dangerous than it was a long time ago. So you want to be able to explain that to them. And then always addressing the root concern. So I get the hesitation about radiation. The challenge is that standard 2D x-rays don't show me enough to help you effectively. And once again, it comes down to this doesn't take the liability off your hands, so you have to protect yourself and be able to take the images that you need to be able to treat a patient to your standard of care. All right, that wraps up our our talk for today. I really like, different radiology memes, so sorry in advance. I like that one. But now I would like to acknowledge the collaborators that I had on this project, especially Dr. Martina Perrone. Thank you so much. Everyone at Beam Readers is really great. Mentorship wise, I can't speak highly enough about my time at the company. So thank you to these people. And questions. We are gonna open it up for Q&A. I also put my email here if you ever have any specific questions that you're looking for an answer from a radiologist for. Happy to answer if you come up with something later, but I would love to be able to have a discussion now if anybody wants to ask a question.
Samantha, we had one person in the chat ask, what's the standard of care for getting CBCTs for new patients or recall, and how often should we be getting the CBCT? I think this question popped up before you went into the advantages and disadvantages, but if you want to just kind of answer that.
Yeah, that's
from that. Yeah.
Great question. Obviously, really enmeshed in what we talked about today. But I would say the standard of care is personalizing CBCT scanning to each individual patient. So we should not be blanket taking CBCTs really for any purpose. It's going to be with each specific patient. Is there information that I can't get from my routine 2D imaging that would change my treatment plan? That's the bottom line.
Great. Thank you. Does anybody else have any questions? Feel free to unmute or in the chat. Either one is fine. We had a question about cost. How much are people charging for a 5x5?
That's a great question. I don't know, Martina, do you want to jump in with that one?
I think it ranges all over the place. As Samantha alluded to, sometimes people give it away for free. I had somebody once say to me that I don't want the x-ray to get in the way of the treatment. And I thought that was the most ludicrous approach to, since when does diagnosis get in the way of treatment? It's the foundation of treatment. So I would look at, how much is your machine costing you? How much is your staff time costing you? How much is can your patient population tolerate? What's the insurance reimbursement rate? There's a lot of different factors that go into that. And so it's really hard to answer that. And I think, you can buy those price lists. That's honestly where I would start, is what is that you can, for a code, you can say, there's small volume code, and look at what your zip code is. And if you want to be in the 50th percentile or the 60th percentile, the 90th percentile of your zip code.
Yeah, I think I agree with Martina. That's a great way to start. Look at your other procedures and where your prices for those things compare to other offices nearby, and kind of price accordingly. And then the one thing that I can share would be about radiology reports. So at Bream Readers, I think it's currently 110 for report. Kind of depends on how many a week or a month you send in. It's been at that level for a long time. But a lot of dentists that I know, if they do need a radiology report, it's, they see something, they don't know what's going on, or they just want one for the area that the scan is taken. They will just charge that to the patient as well. So they will tell the patient, hey, it's going to be this much for the report, and they put that on to the patient. So
And
let's
just a
see.
quick note on the pricing. So Samantha's right. It's 110 if you're submitting only a few cases. But as you're getting your sea legs with CBCT, I would actually recommend you submit everything. Do your read on the side and kind of test yourself against our reports. Basically, we're giving you the answer sheet. And if you are knocking it out of the park every time, then just use us for the weird stuff. But if we are finding things you're not finding, you may find we even find dentistry for you, and we're paying for the cost of those reports with the dentistry we find for you. So just be aware that there is a price range depending on how often you use us. And in the beginning is the best time to use us a lot as you're figuring out all of this. So it can go all the way down to 86 a report currently.
Yep. And that's a great point, Martina, that even, one finding of something that you didn't quite catch, that is a reason that the patient needs treatment, is probably going to supersede that amount. So it can actually be really helpful in supplementing, your current knowledge with it. So let's see, I saw
Also,
another question pop
yeah,
up. Oh, go
just
ahead.
one more thing about cost, because this one usually comes up. I suspect somebody in the group will have this question is, how do you, when you submit to Beam Readers, how do you bill for that? There's two codes. So there's a CBCT code for taking and interpreting the scan. And if you're writing your own reports, you can charge that. But if you're submitting to Beam Readers, there's a code for just taking the scan, and it's based on the different volumes, and then a separate code for interpretation. And so if you're sending to Beam Readers, you're going to want to bill for the taking and then bill separately for, I think it's D0391 for the interpretation under the Beam Readers.
Yep.
Um, and then really quick before we jump into more questions, I want to remind everybody this series you need to register for each course. So just because you sign up for today's course doesn't mean you'll see the second and third one. So I'm going to drop in the chat the links to the second and third session. So if you haven't already registered for those and you're interested in hanging out with us more, please do so. And then the
Yeah.
next
Thank you,
question,
Martina.
of course.
I was just gonna
Um,
say, I think I promise it's only gonna get more interesting from here. So next time we're gonna be talking a little bit more about actually optimizing how you're taking the scan, like tips and tricks for, you have this super expensive technology, how can we best utilize it? And then the last one, we're gonna be talking more interpretation, anatomy, stuff to look out for, all that kinds of stuff. So if you're interested, please register separately for those two.
Great. And then we had someone comment on taking a CBCT for ortho. Before each ortho, they do that to, to get more, it says to note any concern. So I'm assuming more information. And they do that in place of a Ceph and a Pano now. Any thoughts on that?
Yeah, everybody has different way they do things. From my knowledge of So there's a specific, I think it's one of the position papers, and this is kind of going in the weeds, but talking specifically about indications for CBCT in ortho, in endo, in each of the specific specialties, if you're interested in that. And I believe, for ortho, just taking a scan for general treatment planning is not recommended because it is a higher radiation dose, and these are young patients, so we have to be extra careful. It can obviously be helpful because a lot of the time, that we end up finding something that is indicated for taking a CBCT, like an impaction, something like that. There are a lot of times that it does end up being helpful. However, my personal recommendation would be to do the Ceph and Pan to identify cases when a CBCT is indicated. Any thoughts on that one, Martina?
My kids are actually both in ortho, and one had a CBCT and one did not. So I live and practice that. It's very individual. I think probably 90% of the time when you look at the list of reasons to take a cone beam, as an orthodontist, you're going to be needing the CBCT. And it depends on your machine. So the iCat Flex, if you are able to get your clinical questions answered at a very, very low resolution. So it's a little bit grainy. It doesn't look perfect. The radiation dose is actually smaller on that than it is for many Ceph and Panos. So, it is one of the things Samantha talked about is it's individual medicine. And so you have
Yep.
to really look at what your options and alternatives are and pick the best thing.
Yeah. Yeah. And
Another question
that's
popped.
why I was gonna say,
No, no, go ahead. Yeah.
we shy away from black and white, right and wrong, because, it's really up to you guys to be as educated as you possibly can be, and then make your own clinical decisions about your practice and what is necessary for your practice. So, um, it's always a balance of radiation dose and the information you're going to get. And then correctly optimizing the scan, also so important because you want to be getting all of the information that you can get out of every image that you're taking.
Great. Next question
Next
is,
one.
would you take a CBCT when you're doing a full mandibular graft to see where the IAC is? Sorry, inferior alveolar. We call it the canal because we can't see the nerve. So,
Again, I would go patient by patient, but asking that as a blanket question, probably. I probably would if I'm um, grafting near the nerve. Um, yeah, but it depends on each specific case. If you can see, my dad is actually an oral surgeon, so a lot of the stuff that I have learned about clinical practice comes from him. And when he takes a CBCT, and he takes a CBCT, I think most times that he's doing grafting so that he can see the specific bone height and volume in the area that he's placing an implant. Sometimes it can be a small field of view if it's a single tooth, but if it's helpful and necessary, then you want to take it.
and then will the size 8x8 include the TMJs?
That's a good question. I think typically um, 10 by 10 is the one that includes the TMJs at least, right?
I
Every
I
machine is a little
actually
different. So this is,
yeah. I actually just went through this with an office, so I thought the 10 by 10 would include it, but it doesn't. So they actually need on
okay.
kids, you'll probably get the 10 by 10, but on large males, you will miss it. And so
Yeah.
it depends on what your client base is, but I would recommend um, doing a larger field to get the TMJs included. And you do have the option if your machine doesn't do that, you could do very small volume. We have one school that does 5x5s on each TMJ,
Mhm.
and then they take a pano. And they do the pano because there are impacts from when the TMJ, the TMJ is a growth center for the rest of the mandible. And so it helps us see what happened as that patient was developing and whether that TMD is something that's been going on since they were growing or if it's happened post growth. So we
Yeah.
don't want just the 5x5s. We want 5x5s plus a big picture.
Yeah. But yeah, overall, 8x8, I would not expect to always get the TMJ. Yeah. And then can we send CBCT we take for TMJ report? Yes, we really often write reports for TMJ purposes. So when you send this scan in to beam readers, there's an option to give us as much information as you've got about the reasoning for the scan being taken. So I love as much information as you'll give me because it helps us write a better report. So you want to put that the area of interest is the TMJs. You can put any clinical findings as well. Sometimes they're helpful. And then we can do a whole analysis and give you images and stuff like that.
So I know Samantha went over the TMJ. You can't actually see the disc, and that is absolutely true, but we can infer a lot of information by looking at the bony osseous components and how they relate to one another. And sometimes we will say in our reports, if you have to know where the disc is, then get an MRI. But if you're taking a scan for other reasons and it's included in there, we can often give you a lot of information about them as well.
It's pretty rare that we actually suggest MRI from the TMJ for the TMJs because if if the disc has been displaced or there's something funky going on, really often it'll affect the osseous structures, and then we can see the indications of that, and we'll be able to put that in the report for you. Let's see, if I don't have 10x10 installed on my CBCT, can I have it upgraded to include TMJ? That's a great question.
Are you on an OP 3D, Dr. Cruz? So there's okay, and do you know if you're a pro or on the pro? When did you buy it? Was it in 20? Is it been within the last year? Okay. They're the older machines, they can't do an upgrade on, but I would talk to your rep. Sometimes it's just a software upgrade, and sometimes it's a whole machine upgrade. I think to get to the 10x10, it's just a software upgrade, and I think it's an additional purchase, but the machine stays the same. They just give you a code and upgrade it. If you bought it 3 years ago, it may not have that. Actually, I think you can purchase the 10x10 option on the older one. Yeah, definitely speak with your rep. They'll be able to get you hooked up. I do believe it's an additional fee, but I believe the machine has that capability. Yeah. Any other questions? Does everybody feel confident when to take a CBCT versus when not to?
Anybody wants to unmute too and just ask a question, totally welcome to. This is our time to do that. So thank you. That's awesome. Yeah, so
Is
session
everyone?
2. Oh, go ahead.
Go ahead. I was
I
just
was
going to
gonna
say the
say
same thing.
we're like two parts of the same brain cell right now. Session 2 is gonna be more, okay, patient is in the chair. How do we optimize the scan for getting the most information out of it? And then session 3 is gonna be, okay, the scan was taken. Now what do I do? Most common anatomy that we're looking at. And a little bit about interpretation. So like I said, there is no way, it took Martina and I a really long time in residency to learn everything that we know, and we don't even know everything. So no way to do that in just 3 sessions, but the goal is to get you to a really strong foundational point where you could go and take, more advanced courses and stuff if you're interested to keep the knowledge rolling. So we can do more than 3 sessions. Yes, we totally could do way more than 3 sessions.
Yeah, this is just an inaugural study club, so as long as people are interested, we are ready to do this. Um, I did just drop in a form. If you wouldn't mind giving us all feedback, that would be great. I know that we didn't talk about CE at all. But I'm going to try and get CE for all the attendees here. So that's why you'll see questions about name, email, office location is just so we can get you that CE back. No promises, but we're going to do our best to get that for you for this session as well as the future ones. And since we have extra time, does anybody have, we can, because it's study club format, we can branch out. Does anybody have any questions that are maybe on going to be covered in 2 and 3? We can go do a little teaser and satisfy some
Yeah, if anybody
curiosities.
has any questions about, more the actual taking the scan or the actual interpretation, go ahead and drop them in the chat now, and that way I can, kind of make sure to address them now, or make sure to address them in the future. Or any specific types of cases that you're interested in, I can try to pull example cases of things that we're able to see in CBCT.
I have a question.
Oh, go ahead.
Okay, go ahead. No, sorry, go ahead.
Something I'd like to know more about is kind of that distortion on the maxillary anterior when you're looking at implants in place to determine if there is bone loss or not, and if CBCT is not a good modality for that, what other options we have. That would be something I'd be interested in for future.
Were you talking about the part where we were talking about thin buccal bone, or with like artifact and things like that?
The thin buccal bone.
Gotcha.
And you may have covered some of that. Sorry, my kids were running around, so I might have missed that. If you did, I apologize.
Yeah, so I can just go, well, I can bring up maybe a case for that in the future, but just a little refresher plus a little more knowledge. So because of partial volume averaging artifact, if there's two densities within the same pixel of an image, or within the same you sometimes can't tell if that object is present, because it's going to change the appearance of it on a CBCT. But when we're talking about that, we're talking about super, super, super thin things. So it would be like, is there like, so I could tell you this, if it looks like there is bone present, there is. If it looks like there is no bone present, for example, on, like along the floor of the maxillary sinus, or somewhere within the alveolar ridge, there is a possibility that there is bone, but it's just so thin that because of partial volume averaging, we're not able to see it. So I say take it with a grain of salt, but if you can see bone there is bone, and we can do measurements and that kinds of things. That is totally an indication of CBCT for implant placement. But if you don't see bone, there might be bone present. That is, but it would be super, super thin. So it almost wouldn't even affect, it might be like if you're looking at an implant that is placed where it doesn't look like there's bone on the buccal surface, there could be very, very thin buccal bone. Does that help at all?
Yes, that is perfect. Thank you very much.
Okay, great.
Are you also looking for osseointegration with the implant?
In this particular case, it was the cone beam for other implant placements, and the oral surgeon and the implant guide technician was saying, "Oh, we should take that implant out because it doesn't look like there's any bone there." I said, "Well, but like, have you checked? Because it's solid. There's no recession." So that was having an answer to explain my position on other ways we need to check that besides it just doesn't look like there's any bone there is very helpful.
Yeah, definitely that artifact can be fooling in those situations. If it's clinically stable, I would 100% trust that. I see implants that I am 100% sure are not all the way in bone, that are rock solid and have been rock solid, because we see CBCTs over time, and I'm amazed sometimes at implants being stable given what I see relative to the bone. Even if they're not in the bone, I would trust your clinical findings more than a CBCT in terms of like, am I going to redo it or not? Yeah, great question.
Okay, I have a question. Okay, same thing. How do we avoid the artifacts? Because I just got a report here. The technique is good, but the artifacts from beam hardening, it degrades the interpretation in fine detail according to how do we avoid the artifacts.
Unfortunately, that is one of the limitations of CBCT, that there is beam hardening artifacts with hyperdense or high density structures. So there's really not any way that we can decrease it besides adjusting the brightness and contrast. It's just if there is artifact next to one of those structures, the structures that surround it might be affected. So the best advice that I can give is you have to correlate the findings on the CBCT with your 2D radiographs and the clinical findings. So 2D radiographs are going to oftentimes give you much better idea of if there is recurrent decay next to a hyperdense or radiopaque restoration, and then comparing it with clinical findings as well.
Okay, thank you.
Martina, any other thoughts on that one?
Artifact's a tough one. They're coming out with newer, better algorithms to try and alleviate that. The biggest thing is smallest field of view will reduce the artifact. So if you're taking a CBCT of someone's mouth and they have restorations everywhere, you want to really collimate your beam as small as possible so you're not getting artifact from all the other restorations in there. So smaller field of view is better.
Will there be an AI coming soon to interpret the CBCT scan?
It is. There's a lot of people working on that, and AI has surprised me. So sometimes you're like, wait, how have they not figured that out? And sometimes you're like, whoa, how does it know that, right? And I have had that experience with AI in radiology very specifically. Is sometimes I'm like amazed at what it can do, and when I look at it doing what we call threat detection, so is there anything on here that's going to impede or impact the patient's health? It's not so great at finding everything, right? If I say, hey, does it have this one thing? It can start to find that. And I think we're going to get pretty reasonable detection on some of those things. But in terms of scanning for everything, it's not that fantastic at it. And the subtle stuff, which is what, as radiologists, we live and die for, right? Like that makes our day. Is like, hey, I caught this really subtle thing.
That will, affect the radiologists if the AI will give us the right, the result as soon as possible. When we do implant, when we take the CBC, okay, that's the length, that's the width, right?
Yes. So, yeah. So, I famously said 4 years ago, bring on the machine. I don't want to measure implants. That's really boring. I want to look at all the beautiful fine detail that says, okay, it might be this lesion or it might be that lesion. Put all the puzzle pieces together and figure it out, right? So I think you're going to get AI doing a lot of the easy work. And I think patients actually are going to benefit from that because there's so many cone beams that are not being read right now that should be being read.
Yeah.
The machine will help us out with that. And then the reports that really do need to get to the radiologist will get to the radiologist. And so I hope it comes in all the right ways.
Okay. Looking forward to it. Thank you. Especially now, it takes forever to get the result, right? So if you want the result or the report right away, I think AI will help. It's not 100%, but at least right? Sorry about the
Yes,
radiologist.
our attention span has gotten shorter and shorter as we've grown up, right? I remember I used to be able to sit and do things forever, and now I'm like, let's get on to the next thing. And we're feeling the same way about radiology reports. People used to say a week, great, that's awesome. Now they want it yesterday. We do have a rush option at Beam Readers, though. I'm not sure if you're aware of that, but if you need it tomorrow, we can do that.
Oh, yeah. Okay.
Yeah, and it's not too. I think it's $25, right, Martina? So it's not.
Oh, we can do that as well.
Is that US dollars, Canadian? So for us, it's $100 for 25 US. Is that you're talking about US dollars?
Yeah,
US
that's
dollars.
US. Yes.
Yeah.
Yes.
Mhm.
Yeah, and I will say that with the AI, I totally agree with Martina that the day that it is able to help us do our jobs better and easier, I'm very excited for it. But I have toyed with it a decent amount in terms of identifying pathology. And I think we're very far away from it being able to identify pathology to the degree that you as the dentist need to know, does this need to be biopsied or not? Like, you would not believe the things that it doesn't get in terms of just being way off base. So for right now, I don't think we're there yet. Would love to
we
see
still
us
need
there
the
someday.
radiologist. Sorry.
No, I would just
Awesome.
say healthy skepticism, right? Don't trust it.
Yeah.
Until it's got a lot of data behind it. So, but bring it on. I think it'll make all of our lives easier.
Yeah.
So we've got another question. Examples of soft tissue lesions concern the tongue or tonsils, arthritic changes in the cervical spine, maybe more subtle, early and late.
Yeah, I can definitely bring some examples of those at a future session, probably the third session. I can pull some examples of those kinds of things. Because I love the point about the arthritic changes on the cervical spine, because there is a certain degree of that everybody over a certain age pretty much has. And then there's some other changes that can be more meaningful. And the biggest thing there is to correlate it with clinical symptoms always. That's a really big one.
And then we have another one that has a future question. This will be great for next time, I think. Should we be customized settings for each case? And if so, how? And then diagnosing vertical fractures that don't have bone loss.
Yeah. Like customizing settings, I think we can dive more into next time, because that's going to be, it depends on what machine you have. Yeah, but there's some, blanket stuff, statements that we can definitely make. And then diagnosing vertical fractures that don't have bone loss. So vertical root fractures are really tough. Obviously, if you can't see them on 2D radiographs, it is indicated to take a CBCT. It's very important to know that CBCT cannot always visualize vertical root fractures because it depends on how large they are and the location that they are. And if the tooth is obturated, sometimes that can create some of the artifacts that we talked about previously. So the answer is, if one is present, you may be able to see it. And so I actually just had, I had a patient a little while ago who we suspected a vertical root fracture on a tooth. And it was kind of like, hey, there's this technology where we can take this 3D x-ray of your tooth. We might be able to see this thing that we're looking for if it's there, but we also might not be. And so it's kind of a spot where if you, want to be able to avoid retreating an endodontically treated tooth by potentially seeing a vertical root fracture, having to retreat it and then extract it when it inevitably fails, it might be worth it for the patient. But if it's not, if you don't want to risk not being able to see it when it might be present, you just have to take that into consideration. Any thoughts on that, Martina?
I agree with everything you said. I did my master's on vertical root fractures, and so if there is not separation, you will not see it. One thing to keep in mind, though, is bone loss happens relatively quickly with it. So while you may not see that huge J defect that we all learned about in dental school, you will probably see a small, it looks like a periapical lesion, but it'll be at, along the root, right where the fracture ends. So you can often, it looks like a lateral canal has a periapical lesion.
Yes, even if we can't see the actual fracture, there could be another subtle finding that it's only on the CBCT that does allude to, likely. And that's something that we would put in a report too, if you got a report taken for something like that. Even if there's not a definitive fracture found, we would be able to say something like, while there's no definitive fracture visualized, X, Y, and Z findings are highly suspicious of a vertical root fracture. And then that can help kind of guide your treatment plan.
Exactly.
Any other questions for today? These were great.
Are most people on this call, are your machines this year or older? Are you in the OP3Ds? Anybody have ICAT? Just curious as we get prepared for the next session next week.
OP3D for me.
Okay. And do you know if you're Pro, Max, or older? Pro. Okay.
Yeah, it was bought this June, so the most recent.
Okay, great. Welcome to the world of CBCT.
Thank you. Glad to be here. Thank you for this great study club session and going forward. I'm very excited about it. So thank you both.
Yeah,
awesome.
We appreciate you guys doing this relatively last minute. So this is great.
Okay, great. A lot of OP3D.
Any other burning questions?
I'm going to share my screen one more time. Can you see my email up there, Martina?
Yep.
If anybody has anything else any other burning questions for the second and third session that you think of, feel free to shoot me an email or certain type of case you'd like to see, and I'll try to include that.
I just dropped it in the chat too, if y'all want to just copy and paste.
Perfect.
Great. Well, thank you so much, Samantha. That was wonderful. As you can see from the feedback, it sounds like we're on the right track.
Awesome. Well, then I will let everybody move on with their day. Thank you so much for joining us and for your participation. It makes it so much more fun. So we'll see you next time for the second and third sessions. Make sure you sign up for those. And thank you, Martina.
Okay, I signed up. Thank you so much for your time.
Yeah, thank you.
Excited to the next one. Thank you.
We're excited to have you,
All
Dr.
right.
Seuss. Also, please fill out the feedback form too.
Okay. Okay. Thanks.
Thanks so much, everyone.
Have a great day.
You too.